So the basic concepts here are the normal blood pH is 7.35 to 7.45, and anything less than 7.35 is considered acidosis, and more than 7.45 is alkalosis. So what are the acids here and bases? Acids, the substances which releases H plus ions into the solution. They are carbonic acid and lactic acid. Bases that accepts H plus ions or release hydroxyl ions. Examples are bicarbonate and ammonia. So buffer system. It prevents drastic changes in the pH by neutralizing acids or the bases. Bicarbonate buffer system and phosphate buffer system. And two systems involved here are lungs, they regulate CO2 levels by altering breathing, and kidneys, they regulate H plus ion excretion and bicarbonate reabsorption. The normal ABG values. pH is 7.5 to 7.35 to 7.45, and average is 7.4, and PCO2 35 to 45 mmHg. We take average as 40. Bicarbonate is 22 to 26 milliequivalents per liter. We take average as 25. PO2 is 80 to 100, and SPO2 95 to 100%. So here, what is metabolic acidosis and what is metabolic alkalosis, and what is respiratory acidosis and what is respiratory alkalosis? So we call metabolic acidosis if bicarbonate is decreased. Metabolic alkalosis if bicarbonate is increased. Respiratory acidosis if PCO2 is increased. Respiratory alkalosis if PCO2 is decreased. This is the basic concept here. Then what is anion gap? Anion gap is the difference between the measured cations and anions in the serum. So the formula for the anion gap is sodium minus chlorine plus bicarbonate. So the normal value lies between 8 to 12 milliequivalents per liter, and when it is called high anion gap is when it is more than 12 milliequivalents per liter. So types of acid base disorders: we have metabolic acidosis, we have metabolic alkalosis, respiratory acidosis, respiratory alkalosis, and there is one more called mixed disease also. So we need to note is whenever there is a metabolic derangement, respiratory system tries to compensate it, and whenever there is respiratory disorder derangement, and metabolic system tries to compensate it. So for metabolic derangement, respiratory system will compensate it very quickly, but for respiratory derangement, the metabolic compensation will be very slow. So metabolic acidosis, there are two types: high anion gap metabolic acidosis and normal anion gap metabolic acidosis. So high anion gap metabolic acidosis, it is accumulation of the unmeasured anions like lactate, ketones and toxins. So we have a mnemonic for this. It is mud piles: M for methanol, U for uremia, D for DKA, P for paraldehyde propylene glycol, I for iron and isoniazide, L for lactic acidosis, and E for ethylene glycol, and S for salicylates. So normal anion gap metabolic acidosis, it is not due to addition of any unmeasured cations, unmeasured anions. It is due to loss of bicarbonate ions. So there are two causes, GA causes and renal causes. For GA causes, in GA causes we have diarrhea, pancreatic fistula, and ureterosigmoidostomy. In renal causes we have renal tubular acidosis, Addison's disease, ACE inhibitors, spironolactone, esdijolamide. So what is the ABG here? So in metabolic acidosis, the pH will be decreased. As it is acidosis, the pH will be decreased. So what about the bicarbonate ion? So it is metabolic acidosis, bicarbonate will be decreased. What about the PCO2? as it is already in acidosis, the respiratory system will try to compensate it. So the respiratory system will try to make it alkaline. So the PCO2 will be decreased. As we know that increased PCO2 is acidosis. Then what are the complications of metabolic acidosis? Uh, as we know, here it is metabolic acidosis. There is increased H plus ions in the blood. So the body will automatically try to compensate it. So will try to decrease the H plus ions in the blood. So the body will try to push H plus ions into the cell. So to maintain the electron neutrality, and some positive ion from the cell will be thrown into the blood, and it is K plus. So potassium will be increased in the blood, in plasma. So it leads to hyperkalemia, and hyperkalemia leads to erythemias. Hyperkalemia and erythemias. Then and so the second one is the increased H plus ions in the blood will stimulate chemoreceptors. They stimulate respiratory center, and it leads to hyperventilation. So the CO2, the carbon dioxide will be thrown out. So it will be seen as increased respiratory rate and increased tidal volume, and there will be hypotension eventually. So we know that when there is metabolic derangement of the metabolic acidosis, the respiratory system will try to compensate it. So what is the compensator formula for the metabolic acidosis? So it is Venter's formula, and it is given as CO2. The predicted CO2 for the compensation is 1.5 into HC3 bicarbonate value plus 8 or and plus or minus 2. The next one is metabolic alkalosis. So it occurs when the plasma bicarbonate ion level increases due to the loss of H plus or addition of the bicarbonate ion. So what is the pH? So what is the ABG? ABG picture. How is the ABG picture? How will be the ABG picture? As it is alkalosis, the pH obviously more and will be increased more than 7.45, and HCO3 will be more. And to compensate, it is in alkalosis, respiratory composition will be acidosis. The PCO2 value should be increased. So what are the causes for the metabolic alkalosis? So it is based on the urine chlorine level. If it is urine chlorine is less than 15 milliequivalents, it is called as chlorine responsive metabolic alkalosis. If urine chlorine level is more than 15 milliequivalents, it is called as chlorine non-responsive metabolic alkalosis. And in under chlorine responsive metabolic alkalosis, we have vomitings, villus adenoma. Under chlorine non-responsive metabolic alkalosis, we have Bartter syndrome, loop diuretics, and Gentleman syndrome, thiazide, and aldosterone usage. What is respiratory acidosis? So for respiratory acidosis occurs when the PCO2 is increased. PCO2 is increased. It is of two types: acute and chronic. Acute, it is rapid onset, and chronic, it is gradual. And only in the chronic respiratory acidosis we have the kidneys compensation. In acute we don't have the kidneys compensation. So what is acute? It is sudden increase in the ventilation leads to the CO2 retention. Sudden decrease in the ventilation leads to CO2 retention. It is seen in airway obstruction, acute airway obstruction, in case of foreign body obstruction, and drug overdose like opioids and sedatives, and in some conditions like neuromuscular weakness, example Guillain-Barré syndrome. So chronic, it is gradual, and kidneys will eventually tries to compensate it. And example for is typical example is COPD and OHS. So what are the pH? What is the pH, and what will be the PCO2, and what will be the bicarbonate ion in this? So pH, obviously it is acidosis, so pH should be low. and respiratory stress, it is respiratory stresses, so the PCO2 should be increased and more than the normal. And as it is in acidosis, the metabolic system will try to make it alkaline. As it is in acidosis, the metabolic system will try to make it alkaline, so the HCO3 obviously increases. So what is the metabolic compensation for the respiratory stresses? And we know there are acute conditions, chronic conditions. In acute condition, for every 10 increase in the CO2, there will be 1 increase in bicarbonate ion. And in chronic condition, for every 10 increase in CO2, there will be 4 increase in bicarbonate ion. And for this value, we have to add plus or minus 3 to get the compensation. So what is respiratory alkalosis? Respiratory alkalosis occurs when blood PCO2 is decreases. It is also two types: acute and chronic, and rapid onset, gradual onset. Acute is rapid onset, chronic is gradual onset. And in acute we have a in conditions, in which conditions we see acute respiratory alkalosis. It is in panic attacks, acute pain and fever. So chronic respiratory alkalosis can be seen in chronic high altitude exposure and pregnancy. So what is the ABG picture? What will be the ABG picture in respiratory alkalosis? As it is alkalosis, the pH will obviously rise, and as it is respiratory alkalosis, the PCO2 will be decreased, and to compensate it, the CO3, as it is in alkalosis, the bicarbonate will be decreased to make it acidic. So what is the metabolic composition for respiratory alkalosis? In acute conditions, for every drop in 10 CO2, there will be 2 drop in HCO3. And in chronic conditions, for every 10 drop in CO2, there will be 4 drop in bicarbonate. So for the value we attained, or the value we got, we should add plus or minus 3 to get the actual compensated value. So let's look into this ABG. So here we have pH is 7.195, pH is 7.195, and PCO2 is 16, then HCO3 is 6. So let's find it, what it indicates. pH is 7.195, so it is obviously acidic. So it is acidic. And what type of acidic it is, whether it is respiratory acidosis or metabolic acidosis. So then we should look for PCO2 and bicarbonate ion. So if bicarbonate is decreased, it is metabolic acidosis. If PCO2 is increased, it is respiratory acidosis. So here we have bicarbonate value is 6. What is the normal value? What are the normal value of bicarbonate? Is 22 to 26. So it's obviously decreased. So it is metabolic acidosis. So next we have to find whether it is compensated by the respiratory system or not. For that we have one formula. It is 1.5 into HCO3 plus 8 plus or minus 3. So 1.5 into, what is the truth value? 6 plus 8 plus or minus 3. So it is 9 plus 8, 17 plus or minus 3. So the range will be 17 minus 3, 14, to 17 plus 3, 20. So the PCO2 value should lie between 14 to 20. Here the PCO2 value is 16. So it is compensated. So it is metabolic acidosis with compensated respiratory alkalosis. Here the pH is 7.5 to 2. pH is 7.522 and PCO2 is 41.7, HCO3 is 34.1. So pH is 7.522. It obviously indicates it is alkaline. Alkaline. So whether it is metabolic alkalosis or respiratory alkalosis, we need to find. So for to be called as respiratory alkalosis, the pH, the PCO2 should be less than 35. Here it is 41.7. So it is not respiratory alkalosis. So to be called as metabolic alkalosis, the pH, the HCO3 value should be more than 26. Here it is 34.1. So it is metabolic alkalosis. So let's find out whether it is compensated or not. We have formula for the compensation in metabolic alkalosis is expected PCO2 is equals to 40 plus 0.7 into HCO3 minus 24 plus or minus 5. So here 40 plus 0.7, and what is the HCO3 value here? We got 34 minus 24 plus or minus 5. So 40 plus 0.7, 34 minus 24, it is 10 plus or minus 5. So it is roughly 47 plus or minus 5 is equals to 42 to 52. So it closely we got the value here is PCO2 in ABG is 41.2. So in the ABG we got 41.7. So when we calculated it, it is around the range is between 42 to 52. So it is almost equal to the 41.7. So it is compound. Here the pH is 7.1159, PCO2 is 109, and bicarbonate that is 7.3. So pH is 7.159, PCO2 is 109, and bicarbonate is 37.3. As clearly we know pH is less than 7.35, it is acidic. Next we need to know whether it is metabolic acidosis or the respiratory acidosis. So the respiratory component is here is 109. So clearly it is more than the 45. So the PCO2 is increased. So it is respiratory acidosis. Then we should find whether it is compensated by the metal component or not. So we know for every 10 mmHg rise in the CO2, there will be 1 millimole per liter rise in bicarbonate. Here, if you take PCO2 40 as a normal value, the value shown in the ABG is similar to 110. So it is increased by 70. So there is 70 mmHg increase in PCO2. For that, to get compensated, the bicarbonate should be increased by 7 millimoles per liter. So what is the normal value of bicarb? Normal or average value of the bicarb is 25. For this we should add 7. We got around 32. To get the estimated value of bicarbonate in respiratory acidosis compensation, we should add plus or minus 2 minus 3 for this value. So we got 29 to 35. It is very close to the 37 we have here. So finally it is respiratory acidosis with compensatory metabolic alkalosis. So let's look into the one more example. Here the pH is 7.578, PCO is 19.7, and HCO3 is bicarbonate is 18.4. pH is 7.578, PCO2 is 19.7, bicarbonate is 18.4. So we clearly know that the pH is in alkaline as it is more than 7.45. To know whether it is respiratory alkalosis or the metabolic alkalosis, so to have or to get metabolic alkalosis, the bicarbonate should be more than 26, but it is 18.4, so it is clearly not the metabolic alkalosis. So next we have PCO2 19.7. So when the PCO2 is less than 35, it is in alkalosis, so it is respiratory alkalosis. And next we need to find whether it is compensated or not. So for every, the compensation here is for every 10 decrease in PCO2, there will be 2 millimole per liter decrease in bicarbonate. So here in this example, PCO2 is decreased by 20, as the average is 40, it is 19.7, so it is decreased by 20. So then HCO3 bicarbonate should be decreased by 4 millimoles, as for every 10 there is 2 millimole decrease. So for here it is 20, there will be 4 millimole per liter decrease in the HCO3. So what is the normal value of HCO3 is 25. So 25 minus 4, 25 minus 4 is 21. To this we should add plus or minus 3 to get estimated bicarbonate compensation. So 21 minus plus or 3, it gives 18 to 24. So the value here is 18.4. So we can say that it is respiratory alkalosis with compensated metabolic acidosis. So let's look into another example. Here the pH is 7.149, 7.149, and PCO2 is 39, and bicarbonate is 13. So we can clearly see it is pH is 7.14. It is in acidic, and which contributes to this acidic nature, bicarbonate, which is 13. So it is metabolic acidosis. So next we should look for whether it is compensated by the respiratory system or not. Compensated, compensated or not. And we have formula for that compensation in metabolic acidosis is PCO2. PCO2 is 1.5 into HCO3 plus 8 plus or minus 2. Here 1.5 into 13 plus 8 plus or minus 2. So 1.5 into 1.5 into 13 is 19.5 plus 8 plus or minus 2. 19.5 plus 8 is 27.5 plus or minus 2. It is 25.5 to 29.5. So the PCO2, the estimated PCO2, the expected PCO2, to say it is compensated, the value should lie between 25.5 to 29.5. But here in this example, the value is 39. So it is more than the expected value, more than the expected value. So here we can say that it is metabolic acidosis with respiratory acidosis, because in this example, in this ABG, to in metabolic acidosis, to get compensated and the respiratory component, the PCO2 must be lie in the range of 25.5 to 29.5, but it is more than this. It is here 39. So it is in acidic nature. Here the example is of metabolic acidosis with respiratory acidosis. So it is called mixed disorder.